I'm going to set this up a little bit, make an introduction. So Jeff Barnes, Dr. Barnes, is a colleague and friend, certainly a friend of mine, but a friend of the Value Partnerships and CQIs as well. He's the co-director of MACI, which is the Anticoagulation Collaborative. Jeff is a cardiologist at Michigan Medicine and University of Michigan, and an expert, truly an expert on venous thromboembolism. And I would say, has a national expertise in particular on how COVID is interacting with VTE risk in patients. And, we heard loud and clear from all of you that you needed somebody to talk authoritatively on this topic. And we did our best to find Jeff, and he did his best to give us some time to talk to us. So Jeff, welcome, and floor is yours.
Well, Keith, thank you so much. And it's really an honor to be here with this whole group. I'm really excited to be speaking with you. And as you said, I'm going to spend a little bit of time here today talking about some of the evidence, and then hopefully raising an opportunity to have a little discussion or have some questions. Before I start, I do want to make sure that my disclosures are transparent, and that I have done some consulting work from companies largely that manage anticoagulants or make anticoagulants. And I do run the MACI CQI through Blue Cross, as Keith mentioned. I want to frame our discussion here for the next about 30 minutes or so in a clinical case. And this is a case of a patient who was recently in the ER. This is a 62-year-old man, comes in with 4 days of progressive cough, myalgia, some sore throat, developed a fever at home and worsened shortness of breath. And that really tipped him over to say, let's come on in and get evaluated. Like many of our patients, he has a history of obesity. That BMI is 32. He's a diabetic and has diabetic nephropathy with an elevated creatinine. He's got some hypertension in there. And he has a history of coronary disease. He actually had a stent placed about 4 years ago. He's a former smoker and unfortunately, like many folks, has not yet been vaccinated against COVID-19. And you'll see here, he's got a low-grade fever. He's borderline tachycardic. He's a bit tachypnic. That respirate is up there, but his blood pressures are holding steady. And he is a little bit hypoxic, but about 3 liters of oxygen are able to get him up into a more normal range. And then you can see his labs there at the bottom. Typical white count, the platelets are borderline low, but that D-dimer is really quite elevated. And he has that negative procalcitonin, as well as a creatinine that's up just slightly from his baseline. This is a similar X-ray to what he had. I had to pull something from the literature rather than his. But as you can see here, he's clearly got some ground glass opacities and even a linear opacity that you see there with that black line. And so I think at this point, one of the questions or one of the sets of questions that you could ask yourself is this gentleman at risk for VTE? And especially if he is formally diagnosed with COVID-19, how does that impact his potential risk for venous thromboembolism? Should any PE or DVT dedicated imaging be performed for him? And should we think about initiating anticoagulation? And so I'm going to try and present a little bit of the data that, while it may not give you a firm answer, hopefully can help you think through some of these questions, because I'm sure these are questions that all of our ER colleagues are dealing with on an almost daily basis. Let me start by trying to understand what we are talking about from a scope standpoint. If you're like me, when the pandemic first hit, one of the things you began to hear about was this high rate of thrombosis. And of course, those of us who do thrombosis work for a career sort of said this was our chance to come in and, sort of save the cavalry, so to speak. And it's really been interesting to watch this develop over the last 2 years. This is a meta-analysis of about 40 some different studies trying to estimate the risk of venous thromboembolism in hospitalized patients with COVID-19, because that's really where most of the initial data came out. So this summarizes about the first 6 months or so of data from the COVID-19 setting. And as you can see in the lower left corner, the overall estimated rate of VTE was about 17%. That's pretty strikingly high, if you ask me. But there were some really important caveats in this data. The first was the setting in which the patient existed was a huge predictor of whether or not they were at risk for VTE. The ICU patients, almost 1 in 4 to 1 in 3 about 28% had a VTE, while the ward patients, much lower rate, only about 7%. We see more DVT than we see PE. And interestingly, there was a huge variation in sort of the geographic location. Folks in Europe and the rest of the world had higher rates of VTE than we were seeing here in many of our North American studies. So it kind of raised some questions as to what's the absolute truth. And for me, really raised the important point that we have to be careful about the methods in which some of these data are being collected, because there's always this opportunity for overestimation, underestimation, and bias. I want to look at a couple of the reports specifically in the ear, because I know that's of most importance to this audience. There were some early reports, mostly single center things here and there. On the left, you can see a single center in France where they looked at a little over 200 patients who went for CT scans because they had suspicion of or were being evaluated for COVID-19 pneumonia. About 150 or so were actually confirmed to have COVID-19, and roughly half of those were actually CT pulmonary angiograms, so you could evaluate for PE. And they found that they had 13 cases, or an 18% case rate for PE amongst that cohort. Shockingly, that was almost the exact same as we saw in a single center from New York City. Similar time frame. Both of these were looking at that March-April time frame. The New York City one actually did sort of a pre-post. They compared April of 2020, early in the pandemic, to April of 2019, before the pandemic. And what they found there was that prior to the pandemic, their number of patients that had a PE was much lower, only about 7.5% or 8%. But in the pandemic, a much higher rate, closer to 18 or 19% of folks having a PE. And they said about 2/3 of those or so were actually COVID positive. So again, sort of sending this message that, hey, maybe there's a lot of VTE going on in patients who are COVID positive presenting to the emergency department. But then there was a little bit of a larger study, and this was one from 26 ERs across Europe, Chile, and Canada. Again, early in the pandemic, so we're talking February, March, April 2020. In this case, we're looking at more than 3,000 patients. And interestingly, whether the patients had COVID-19, that's the 974 on the left, or patients did not have COVID-19, that's the 2279 on the right, the percent of those who had a PE was exactly the same, 15%. So I think this is where we start to see some data to say, hey, wait a second, maybe there's not actually this markedly elevated risk of PE amongst the COVID population. And I think this raised a number of concerns. And this is actually pulled from a paper that some of our colleagues at Sinai, Grace, DMC, and Wayne State wrote. And they said, we have to be really careful about these early estimates because we cannot establish a disease prevalence if we're only looking at data for patients who are undergoing testing. There's a really important, what they call the referral filter, or I would refer to as a referral bias. In one way, you could be overestimating the risk of PE because many of the lower risk people, we avoided those CT scans. Keith just mentioned this. We were concerned about the infection risk and to the staff and even to the machines. But also, we may be picking up small PEs that would otherwise not be clinically identified if we're planning to scan more people than we otherwise would have. So that could have shifted us into this overestimation number. At the same time, we may underestimate because we may avoid CT scans in favor of empiric treatment. We might just say, hey, rather than scan them, let's just go ahead and treat them. Or patients may experience a sudden cardiac death and from their PE, they never end up showing up in the emergency department. We know that happens even before COVID. So it's unclear exactly what the true estimate of PE is amongst this group. And then lastly, and I think this is maybe one of the hardest yet most important points, is that each wave of COVID-19 has really brought with it different characteristics. And I mean different characteristics of the virus, different characteristics of the disease process that we see, and different patient populations that seem to be affected. Most of us, I think, became very familiar in that first wave with a much older, sicker population. So it was the elderly, it was those with significant comorbidities like obesity and renal insufficiency. But as subsequent waves have come along, we've often seen a younger and sometimes healthier population become infected with COVID-19. And we know that that's going to have different implications for the patients. We have a couple other larger registries that we can look to as well that tell us a little bit more of a broader picture. This first one comes from the Mass General Brigham Registry. This is a conglomeration of Massachusetts General Hospital and Brigham and Women's Hospital in Boston. And they conducted this Corona VTE study of a little over 1,000 patients, again, very early in the pandemic. But what they show here, which I think is really interesting, is the difference in rates of VTE between those in the ICU, the floor, and now we're finally starting to get some data on the outpatients, those who were never admitted to the hospital. You can see this was a younger population, about an average age of 50, half male, female, and a largely non-white population, so quite a bit of diversity. And if you look at that box on the left side of the screen here, this is the symptomatic VTE, so PE and DVT taken together. Again, the ICU patients, very high rate, a little more than a quarter of them. But the floor patients had a much lower rate, only 2%. And importantly for this discussion, outpatients had a 0% rate of PE or DVT. And so really we see that the severity of the COVID-19 infection, or at least how the patient's presenting, really correlates strongly with their risk of venous thromboembolism. And frankly, that was largely mirrored in an even larger study from Kaiser Permanente, Northern California. Now we're getting a chance to look at well over 200,000 patients in sort of that first wave of the pandemic. They had 26,000 who were COVID positive and almost 200,000 who were COVID negative. And I put a box here around the outpatient group, and you can see those numbers are fairly low. We're talking about 2% overall. And they're equal between those two. So again, it's starting to suggest to me that in the patient who's not sick enough to require hospitalization, they're simply coming in for a diagnosis of COVID or something else, the risk of actually developing VTE is quite low and maybe is not as high as we initially thought when we were talking about or closely associating COVID infection with thrombotic events. We also have this data from 150 U.S. Emergency departments, and Jeff Klein really has led this effort out of the Recovery Registry, where they tested folks who were suspected to have SARS-CoV-2 or COVID-19. And what you can see on the bottom here, again, we're talking about 14,000 COVID patients and 13,000 COVID negative patients. The rate of VTE over 30 days was similar. Roughly 1.5% in both of those groups. So again, supporting this notion that it's not an overly high rate here and that there don't seem to be huge differences just because of COVID infection. Now, some people will say, well, what about the person who was hospitalized for COVID-19? What's their risk of VTE afterwards? And I think that's a great question. Many of us have seen anecdotally these patients who come back maybe a week after discharge and they're found to have a PE, and that makes us concerned. We don't have great data. This is probably some of the best data that we have. In this case, there was a group that looked at just shy of 500 consecutive patients who were hospitalized for COVID-19. They were actually able to analyze data on almost 150. So again, big selection bias here. And what they found is that the D dimers remained elevated even out to 6 weeks in about a third to almost a half of these patients. So we do see bio evidence, we do see biomedical and biomarker evidence that there's ongoing sort of COVID abnormalities. But look at the asymptomatic and symptomatic DVT and PE rates, one in each group, less than 1%. So yes, we will see these folks coming in. And of course, with so much COVID in the community, folks were going to have PEs and DVTs anyway. But we're not really seeing an overwhelming literature telling us that in the non-hospitalized patient that there is this high increase in venous thromboembolism risk. Do they have hemoptysis? And is pulmonary embolism the most likely diagnosis? If you answered no to all of those, then you could use a higher D-dimer cut point. If you had none of those factors, so no sign of DVT, no sign of hemoptysis, and PE was not the most likely diagnosis, you could use a pretty high D-dimer threshold of 1,000 and exclude pulmonary embolism. If you had a couple of those factors, well, then you might need to use a slightly different D-dimer threshold. And with that, they were able to reduce the overall number of PEs. Now, the question really that I like to bring up here is this group, or one of the groups that sort of uses this algorithm pre-COVID, continued to use that in the first phase of the COVID pandemic. And what they looked at was their data from April and May of 2020, where they said, okay, how successful was this in continuing to allow us to avoid PECT scans? So they looked at 700 patients over this 2-month period, and using the year's criteria, they were right away able to exclude about 40% of folks who never needed a PECT scan because they didn't have risk factors and their D-dimer was sufficiently low. And then amongst those who actually did have a PECT scan performed, what they found was their overall positivity rate was around 13%. And so it gave us some suggestion that, this probably was an okay path to go down. And notably in that group of 273 with no PECT, they did not have any subsequent events that happened afterwards. So provided some reassurance there. One of our key elements is really asking the question, can we use a D-dimer? And we've talked about how the D-dimer is often elevated in folks with COVID-19. Can we still use that as a really good strategy for helping us identify who doesn't have a PE and therefore avoid CT scans? And so these are just 3 studies from patients with COVID-19 suggesting, I think we probably can. So on the left, you can see this is a study from one center that looked at all the folks who were COVID positive on the left side of the screen, on the left side of the graph, and those who were COVID negative on the right side of the graph. And yes, those who had a PE had on average a higher D-dimer level than those who were negative for a PE. In this next one over here, you can see an ROC curve, or receiver operator curve, estimating the C statistic. How predictive is a D-dimer for ruling in and ruling out PE? And you can see that the C statistics are actually pretty good. This is a pretty good looking curve here. And of course, if you go to the right, you see the same thing. These AUCs are all around sort of 0.8, which really is quite good. And so it does say that, yes, these are probably good, but lots of people have an elevated D-dimer because of COVID-19. And so we can't rely simply on COVID-19 as the trigger for ordering CT scans. We need to put it into that greater context. And this is really some data that I think helps us think through this. On the left side, you'll see here a number of studies that say, if the D-dimer is less than 1,000, the negative predictive value for a DVT or a PE is pretty good, somewhere on the order of 90 to 98%. However, what we see is lots of patients who are admitted to the hospital, especially those in the ICU, have elevated D-dimer levels. And so there are other reasons for that D-dimer to be up other than just the PE risk. On the right side, these are 4 different studies that were trying to figure out what would be an appropriate cut point for D-dimer in the setting of COVID-19. And you can see they range. So the first study here suggests about 2,500. The next one suggests about 5,000. The fourth one down here again says about 2,500 is really a key odds ratio differentiator. So we may want to think about higher D-dimer cut points as being the triggers for when we're going to say, that person really does need to get worked up for a PE, because we know that COVID itself can lead to elevated D-dimers. I don't want us to forget that we shouldn't be using D-dimer just by itself, but really it needs to be combined with a pretest probability estimate like the Wells score, for instance. Here's one center that looked at patients who had Wells scores of either less than or equal to 4, in which case they ordered a D-dimer, or Wells scores of greater than 4. And you can see that if the Wells score was less than or equal to 4 and the D-dimer was low, a traditional 500 or 0.5 cutoff, only 1 out of those 45 patients had a PE. So that's a good group that you can safely say probably doesn't need a lot of workup. But if that D-dimer was elevated, you see a lot more PE. And of course, if your pretest probability is high, well, then those patients all also had a PE. So making sure that we're incorporating the D-dimer with our pretest probability and not just making decisions on the D-dimer alone. I want to transition for a few minutes here before we get to the Q&A and talk a little bit about the so what, like what happens after the patient leaves your emergency department, and how might some of what we as internists are doing how might that influence a little bit of your all decision making? Because I think it may be enlightening for a minute. So let's talk about some of the clinical trials in anticoagulation thromboprophylaxis. So the first one is the Active 4B study. This was an NIH sponsored study. They ended up enrolling about 650 ambulatory patients, so non-hospitalized patients with COVID-19. And the goal here was to say, could some sort of an antithrombotic agent prevent VTE events? So they were randomized to one of four arms. You could have gotten a low dose aspirin. You could have gotten a half dose or a prophylactic dose of apixaban. You could have gotten the full sort of standard treatment dose of apixaban, or you could have gotten placebo. And you can see some of the demographics and all for the patients. I'll point out this was a lower risk group. These patients, majority of them had normal D-dimer levels, although about a quarter of them were elevated. But the bottom row here is really the key point. The rate of all-cause mortality, venous thromboembolism, arterial thrombosis, MI, stroke, and cardiopulmonary hospitalization was exceedingly low, about less than 1% to maybe 1.5% across these groups. So overall, this is just not a high-risk group, and therefore they actually stopped the study early and said, we don't need to be giving any sort of thromboprophylaxis to the ambulatory patient with COVID-19. Now, what about the patient who gets admitted to the hospital? Let's start with talking about what we call the moderately ill patient. This is probably the patient who's going to the ward, the general floor, not ICU level, does not require organ support like vasopressors, or does not require, the high levels of oxygen, heated high flow, things like that. And in this multi-platform study, really an international study of more than 2,000 patients, you actually see some benefit when patients were randomized to receive treatment dose or therapeutic dose anticoagulation. They used this new outcome called the organ support-free days. Basically, how many days between 0 and 22 did you go without requiring any organ support? So didn't need to be on ECMO, didn't need to have heated high flow oxygen or a ventilator, didn't need to have vasopressors. And so the more blue this is, the better, because that means the more days without organ support. The red, of course, the really deep red would be all the time on organ support or even death. And so that's what we want to minimize. In this third trial that was published in the BMJ, where again, patients were randomized, about 500 or so patients randomized to treatment dose or prophylactic dose, while this time they really drove down the death from any cause. Now, of course, bleeding is always a concern, and the studies, while none of them showed a statistically significant increase in bleed, we have to think about that. But really taken together, when I look at these three trials, we start to say, you know what, we're probably going to give many of our patients who are on the floor with COVID-19, requiring oxygen, but not requiring organ support, they're going to get treatment dose anticoagulation for thromboprophylaxis. And actually, the new guidelines are really coming out now to support that. How about the patients who are critically ill? So those who are in your ER, but they're so sick that they're now headed to the ICU for organ support. This is the same multi-platform study, about 1,200 patients. But look here at how much more red you see on that graph, right? And importantly, there's more red in that top group, the therapeutic anticoagulation, than there is in the bottom group, the usual dose group. And so this study was actually stopped early because they said, this is futile. We don't see any evidence that treatment dose anticoagulation is going to benefit an ICU level patient, a patient who's critically ill and requiring organ support. So the guidelines are really saying that if your patients are admitted to the hospital and they're on the floor, let's give them therapeutic anticoagulation while they're in the hospital for up to 14 days. For the patients in the ICU, those are the ones we're going to stick with sort of the normal thromboprophylaxis. And I think this will have some important implications for you all, which I'll get into in just a minute. But I think we can integrate those guidelines with some of the algorithms that exist, including this MEDIC PE algorithm that I know you all are trying to use to reduce the amount of PECT scanning. I talked before about the years algorithm. Obviously, the PERC score is another very commonly used score, and I think it's a great one here. If you have relatively low pretest probability, use that PERC score. And if that PERC score is negative, no further workup is really needed. Now, of course, that can be a little bit difficult for patients with COVID-19 because often they're coming in due to hypoxia. But even if they don't have hypoxia, this is a really great score to use, and let's try and avoid CT scans where we can. If, however, they do have hypoxia or any of these other risk factors, well, this is a great time to think about using the age-adjusted D-dimer, or at least going through your Wells score before using that age-adjusted D-dimer, and then thinking about ruling out who doesn't need any further imaging if you can use the D-dimer with a relatively low Wells score. So hopefully we can continue to use this as a way to right-size how many PECT scans are being ordered. But I think we can take that approach, which is sort of using these risk scores, Wells and PERC and the D-dimer, and say, okay, first pass, who can avoid the PECT scans just like we would have pre-COVID? But then secondly, I would consider what's going to happen to that person when they leave your emergency department. You know, if this is somebody who doesn't require oxygen, they're ambulatory and you're likely to discharge them, this is somebody in whom we're not routinely going to give anticoagulation. So following that algorithm that you all have set out according to the MEDIC collaborative really makes a lot of sense. I would say for those being hospitalized, we might adjust that thinking slightly. If this is a critically ill patient, they're requiring organ support, you're going to end up putting them in the ICU. You know, we're not empirically going to treat them with anticoagulation, but I would ask, would you have done a CT scan for PE had they not had COVID-19? If your answer is yes, if you normally would have performed that, then I think it's very reasonable to perform because it would change management. But I don't think I would do a PECT scan simply because you know that they have COVID-19 and are headed to the ICU. I think what we've seen is that they're likely to get treatment. And if they have evidence of a thrombotic event, that's going to get initiated through their ICU course there. But of course, the majority of patients are going to fall into this last bucket, the moderately ill patient. And this is the ones in whom, when you admit them to the hospital, they're now likely going to start receiving therapeutic anticoagulation for the purpose of thromboprophylaxis. And so again, I don't know that I would order a PECT scan simply because they are COVID positive. If you have other reasons to suspect that they have a PE, well, then of course that diagnosis could change the duration of treatment, and that's a reasonable thing to do. But if not, if you're really thinking this is a slam dunk case of COVID pneumonia, they're requiring 2 or 3 liters of oxygen, I wouldn't necessarily pull the trigger on a PECT because they're going to get a course of anticoagulation when they reach the floor anyway. And we know that the overall rates of PE on the floor patients is much lower than those in the ICU. So I'm going to stop there, and hopefully we have Keith back. Great. And see if there are any questions from the group or any other discussion around this.
Yeah, for sure. Thanks so much, Jeff, walking us through the latest evidence, helping us understand how we should or should not adjust our clinical practice. Yeah, we're open to questions. I certainly have some myself, but want to start with the group if there's any out there.
Yes, we do have a couple. So one is maybe more of a statement to react to, but our system screening criteria includes performing D-dimer, and it is the number elevation that has been confusing when deciding on PE. And these patients were hypoxic, so that's why they were being admitted, and many deteriorated quickly. Not sure if there's an open question there, but it was a statement.
Well, I might react to that just briefly to say, you know, this is the challenge, and I don't envy the position that you all are in, and I have immense respect for the decision-making that all of you in the ER have to go through. I guess the advice that I would give, and I've talked with some other national experts like Chris Cabral and folks like this, is even when you get that D-dimer, if you know the patient is COVID positive, take a step back and think to yourself, how would I think about their pretest probability for PE to begin with? And don't let that D-dimer number by itself drive all of the testing. Let's really try and think about, would they have necessitated imaging beforehand, or would they not even have been on board? And as I showed in that one slide, we may need to think about some higher thresholds. You know, some folks have even said, gosh, when the D-dimer gets up above 2,500, 3,000, okay, maybe now that's really pushing me, but simply something that's between 500 and 1,000 may not be enough to sort of change my practice pattern. And I think that's probably reasonable advice, especially in these newer waves of COVID, where it seems like the overall levels of inflammation and therefore thrombosis seem to be a bit lower.
Fantastic. Sorry, go ahead, Keith.
No, go ahead.
Yeah,
No, I was
okay.
going to say any more. Yeah.
Yeah, we have a couple more. So what is the recommendation for prophylactic anticoagulation of COVID positive pregnant patients that are well enough to be discharged from the ED?
Yeah, that is a great question. And I know that some of the OB societies have some guidelines out about that. And I can't quote them to you off the top of my head. But what I would say is they are not recommending that all pregnant patients receive ambulatory prophylaxis. Really, it's only those who are at highest risk, maybe somebody who has a prior history of VTE. So I would look to those guidelines, and I'm happy to sort of pull them and I can share them with Keith if that would be helpful for the group. But really, it's not shifting a whole lot from what happened even before COVID.
And one more, wondering if there's a Michigan medicine pathway to guide D-dimer and CT ordering specific to COVID positive patients, obviously outside of the medic tools.
Yeah, Keith, maybe I'll kick that one to you and see if, are you guys using anything sort of formally in the ED?
Jeff, I was going to kick that to you. No, we don't. I would say no, I don't feel like we specifically have developed a standardization around our practice patterns with respect to COVID, to be honest. And in part, I think that's part of the reason that we've been hearing so much from our clinical champions and why we reached out to you, Jeff, is because, you know, there is a lack of clarity on the state of the evidence around sort of how to approach this topic.
Yeah, I think you're right, and it's hard, right? Because nobody wants to miss a PE. But at the same time, I think we also have to appreciate that unnecessary testing brings with it harms both to individual patients and to the system at large. And we have to sort of keep that in check. And so I think if I were to sort of give some advice in the space, I would say, take the COVID diagnosis out of it and think to yourself, would you have worked this patient up for a PE without COVID? And then when you bring the COVID diagnosis back in, it should have very minimal influence in any change around that. And so I would rely on sort of all that prior training. I think we're seeing now in these newer waves that the connection between ambulatory thrombosis and COVID-19 is not very high or very strong. And so, I would not make that a big swaying factor.
Yeah, I'm going to pick up on that thread a little bit. I'm curious to hear your perspective on this, Jeff. I feel like we've got a lot of kind of observational evidence, and I'm wondering if you see in the future more prospective kinds of trials that allow us to get more stronger evidence around, should we be adjusting how we approach risk stratification in patients with COVID and VTE or PE more specifically? I mean, is that what we should be expecting? Or is it more, we're going to have to rely on what's been done and sort of how it may play out a bit more in the future as we have more information to bring to the table?
Yeah, it's a really good question. And, I think anytime somebody asks the question, should a prospective trial be done to answer, a clinical challenge? Of course, we want to say yes, right? That's our best quality evidence. And I think in this space, it might be warranted. What I would say is, it's hard to do clinical trials when you're trying to deal with a pandemic. And so I realize why that hasn't been done to date. I also realize that as these waves have changed, the results of a clinical trial performed in one wave may not always be generalizable to the next wave. And so in some ways, I'm almost happy that we haven't done the trial yet, because I'm hopeful that we're going to reach a little bit more of a steady state as far as the level of disease severity related to COVID-19, so that now if we were to kick off a clinical trial around the diagnostic algorithm or acute management, it maybe will have some greater generalizability and can be used sort of for a longer period of time. One of the big criticisms of the trials that I presented earlier is that they all enrolled patients in the first or second wave well before we had Delta or Omicron. And so we don't necessarily know that the event rates would be reflected in the population we see now. That being said, and so even though, yes, I would vote for and support a prospective clinical trial using the years criteria or showing that the PERC rule with a D-dimer threshold of pick your number works really well. The fact that in the ambulatory or outpatient setting, we're seeing relatively low rates of PE, I think maybe would limit a little bit of the enthusiasm. We'd have to be thoughtful about in whom we would apply that, in whom we would enroll and therefore apply that clinical trial to. Are we thinking about the people you're already going to admit because their COVID pneumonia is severe enough? Or are we really thinking about this for the ambulatory patient? And I think separating those two becomes really important.
Yeah, I mean, those are great points. And, I hadn't really thought about till now how, the risk profile of the population getting COVID has really changed and probably changing the dynamics of risk for VTE too. I've heard some chatter about, gosh, we should maybe be thinking about risk of VTE similarly to how we think about patients with influenza, so as a potentially comparable disease. I mean, you think ultimately we're going to be framing ourselves at the final analysis kind of in that way as we approach our understanding of COVID's risk?
So I think that is a really plausible hypothesis. I've learned through COVID not to predict what COVID will do in the future because you're more likely to be wrong than right. But certainly if we look over kind of these subsequent waves, we've seen this sort of change in the population. We've seen a decrease in sort of the severity, the levels of inflammation. And so if that were to continue, then I do think we're sort of approaching a point where this does look a lot like influenza as far as the other disease manifestations. And we know inflammation is a risk factor for thrombosis, right? It's right in there in that Virchow triad that us thrombosis docs love to talk about. So there's a clear plausibility as to why they're linked. But we're probably seeing something different in 2022 than we did in that, spring and summer of 2020.
Awesome. Any other questions from the audience that might have come in?
Nope, not anymore.
All right, well, let's end it there. Jeff, thanks so much for stepping up to the plate for us and helping us understand how to approach these tough clinical questions. Really appreciate it.
Well, thanks so much for having me. I appreciate it.